Good morning. It's a great honor for me to introduce the Earl Wynands Endowed Lecture, which is generously supported by our Heart Institute Foundation. John Earl Wynands was born in Montreal, obtained his medical degrees at McGill University. After his anesthesia training, he joined the faculty at McGill in 1959 and served as chief of cardiac anesthesia from 1970 to 1998. In 1988, he was recruited by the University of Ottawa, and he was chairman here and chief of anesthesia at the Ottawa Civic Hospital and the Ottawa Heart Institute until 1996. He then founded the University of Ottawa Patient Care Simulation Center and was its director for 11 years after his retirement from clinical practice starting in 1997. Earl is perhaps best known in the cardiac anesthesia world for his contributions to the care of patients undergoing coronary revascularization. He wrote a seminal article entitled Coronary Artery Disease and Anesthesia, and this was published in 1967, and it was followed by more than 100 publications over the next 30 years from him. Dr. Wynands was recognized as a leader throughout his career. He served as president of the Canadian Anesthesia Society, president of the Society of Cardiovascular Anesthesiologists in the United States, and he received the highest awards from both societies, a gold medal from the Canadian Society of Anesthesia and the Distinguished Service Award from the SCA. Throughout his career, Dr. Wynands was challenged by his impaired vision. He was legally blind. While chair at the University of Ottawa, he established the first professional assistance program in Canada for impaired and disabled physicians. He was very proud of this. His many contributions to our specialty led him to be awarded the Order of Canada in 1998. Wherever he worked, Dr. Wynands was a great professional resource to his colleagues and students, and all those who had the good fortune to have known Dr. Wynands realized they were touched by a unique and wonderful human being. Sadly, he passed away in November this past year, and we miss him dearly. Now, I would like to introduce our speaker in his honor today, Dr. André Denault. André is a friend to many of us. He is an academic physician with a special interest in ultrasound. His medical qualifications and specialties included internal medicine, 1991, and followed by critical care medicine, before seeing the light and becoming an anesthesiologist in 1996. I had to add that. In 2010, he completed a PhD in biomedical science at the University of Montreal. He's advanced certification of the National Board of Echocardiography and perioperative transesophageal echocardiography and critical care ultrasound. Dr. Denault has written 370 peer-reviewed articles, 74 book chapters, 4 textbooks on perioperative transesophageal and critical care ultrasound. He's been invited as a speaker at local, national, and international meetings. He won several teaching awards, including the Canadian Anesthesia Research Award in 2022 and the Toronto Perioperative Echo Symposium Award in 2026. He currently works as a cardiac anesthesiologist at the Montreal Heart Institute. He's the director of education of the Montreal Heart Institute and co-director of research in whole body ultrasound fellowship program in the Department of Anesthesia at the University of Montreal. Major interests include right ventricular function, venous congestion, brain monitoring, and whole body ultrasound. And just immediately prior to this, André was telling me that he is very enthused about becoming a full-time teacher, potentially this fall, I believe. With that, we welcome André Denault to give us the Wynands Endowed Lecture.
Thank you very much. I'm very touched to be here. For me, coming to Ottawa is something important. In fact, just advance my slides. Okay, sorry. Use this. Oh, sorry. Okay, good. So just before I start, I'm supported by the Lemire Doctors Fund as the Director of Medical Education at the Heart Institute, and the Richard Kaufman Endowment Fund in Anesthesia and Critical Care. My disclosures are shown here. And you all know, and Earl Wynands, and last year, in fact, in April, I came here to visit Earl Wynands because I had giving the Earl Wynands lecture at the SCA, and also heard the Earl Wynands grant at the Canadian Anesthesia meeting. So I wanted to get to know him. So I came here in April and I visited him where he was living, and we spent an afternoon together discussing. And again, as Bernie mentioned, he was really an exceptional human being. And I was touched when he came to the lecture in Montreal, despite the fact that he had some cardiac condition. So I had the chance to talk with him, and he came with his grandson. And then I invited his grandson to come at the Heart Institute to spend a day with me last fall. And after that, we learned that he passed away. I really would have loved to be here during the ceremony, but I was in the operating room. But this was a wonderful interview. I don't know if you saw this by Jimmy Ramsey, where you get to learn Earl Wynands. So I encourage everyone who don't know him to go over this interview. My objectives for this presentation is to discuss the role of right ventricular pressure monitoring in cardiac surgery, to understand how to diagnose RV dysfunction, RV failure, and RV outflow tract obstruction, to explore the effect of medications or intervention on right ventricular waveform monitoring, and to share our preliminary experience using the new Swan, the IQ Swan, with the Alta monitor, which has just been approved mid-April by Santé Canada. So I've been at the Heart Institute since 1999, and I was invited to join the team to develop TEE. That was the reason I was hired, because I had some expertise that I learned on transesophageal echocardiography. And since 1999, several things have evolved. And the way I see them, we can all these developments have played a significant role in our understanding of right ventricular dysfunction. First, TEE in 1999, and then we start using POCUS in 2005. In 2016, we start describing how can we use TEE to examine the lung, because if you have lung condition or atelectasis, that will cause pulmonary hypertension, and that could also influence right ventricular function. And also in 2021, we start describing how can we use TEE to examine the upper abdomen, and for instance, to diagnose one of the major consequences of RV dysfunction, which is portal pulsatility or splenic congestion, which can be done using what we call transgastric abdominal ultrasound. The use of brain oximetry was something we introduced in 2002. We've developed an algorithm, and again, as you will see, when you have a right heart failure, you'll see it instantaneously using this monitor. But also in 2010, we start using somatic oximetry, because if you have a brain and somatic desaturation, you know the problem is not from the brain, it's outside the brain. In 2015, we start using transcranial Doppler in the operating room, and that has been really an eye-opener for us, showing how much air emboli is the major cause of right heart failure in cardiac surgery, and I'll show you some examples. 2017, we start using process EEG, and this was, in Alain Deschamps and I, probably the most important monitor that has changed our practice, the way we give anesthesia, because we realized that we were giving way too much anesthetic drugs. And by adjusting the amount of anesthetic drugs, we really reduced the amount of vasoactive support. In 2002, from 2025, this is when we start using right ventricular pressure monitoring. And this is absolutely useful, because you can instantaneously make a diagnosis of right ventricular failure and right ventricular outflow tract obstruction. And in 2020, we had some experience with the second generation of NIRS monitor, which will tell you if the brain saturation is arterial or venous. And then what we saw with right heart dysfunction is often that the brain desaturation is from venous congestion, and you can see it on your monitor. 2025, we switched to another type of transcranial Doppler, which is a robotic transcranial Doppler. And this is very small size, it's about this size, and it allows automatic adjustment to make sure that you get the best signal for monitoring. And finally, this year, we are experiencing basically a combination with the Alta monitor of all the quantitative elements derived from the right ventricular pressure waveform and mixed venous O2 and also brain saturation. So now we have a monitor that tells you how the right hearts affects the brain simultaneously. Okay, so there's been the evolution at the Heart Institute of our monitoring. So we're lucky in the operating room, we have the ability to display several signals on a single screen. So you can see instantaneously the relationship between what's happening in the heart, what's happening in the brain, and what's also can happen also outside the heart. So when we evaluate RV function, there's definitively three ways that we can use. The one that we have in the operating room is to see the right heart, and the surgeons can tell you right away that the right heart is not functioning. The second technique is echocardiography, either 2D or 3D echocardiography. And the technique that I will discuss with you today is right ventricular pressure monitoring, which allows you instantaneously the diagnosis of RV dysfunction and failure. So if I would tell you that the way that you evaluate the right ventricle echocardiographically would be to examine the right atrium and the pulmonary artery pressure, and that's it, you would say, well, André, that's not what is in the guidelines, okay? It's more than that when you evaluate the right ventricle. Similarly, if you use a PA catheter and you're just monitoring the right atrial pressure and the pulmonary artery pressure, we could also say that's not the way to evaluate the right ventricle because we're missing critical information of what's happening inside the right ventricle. So this idea of monitoring the right ventricle was stressed by, you remember Eric Jacobson from Manitoba, who said that the RV port of the PA catheter should be monitored in patients with RV shock. And in 2019, Meggy Raymond, who was a fellow that you've trained, and by the way, Meggy Raymond and Marie-Ève Chamberlain are two of my colleagues, so well trained. So thanks very much for training them so well. So I'm happy to work with them because they were trained by your team. But Meggy published this paper describing how we use right ventricular pressure waveform. And the idea is that at the Heart Institute, since when I was resident in 1983, they were always using the Paceport Swan because they were always concerned that, if you insert the Swan and there's a block, you can put a pacemaker right away. But then in 2002, we had the idea of transducing that port in addition to the PA, and by doing this, then you have continuous RV ventricular pressure waveform. And last year, we published our experience in ARDS using this type of monitoring. And interestingly, 2 days ago, in fact, 3 days ago, on May 11th, with Louis San, we reported in Anesthesiology our experience or how we use this type of monitoring. And basically, as you will see, how these curves can be helpful to diagnose right ventricular dysfunction and failure. So when we insert a pulmonary artery catheter, what we'll be interested will be to have the combination of the PA and the RV pressure waveform. So as you insert the PA catheter, initially the distal port will show you a CVP and nothing on the pacing port. And then as you advance, you will see the CVP, then the right ventricular pressure waveform, and you still be with the CVP waveform with the RV port. And then eventually you'll have the PA pressure and the wedge pressure and with the right ventricular pressure waveform. So one important element is that when we use, this was the original Swan, when we start doing this, we just want to have the RV and the PA. We don't wedge. So there's no need, especially when you do TE, to wedge because there's always a risk. And what we want is just the PA and the RV waveform because to estimate the filling pressure, we have other techniques with TE that tell us that, the filling pressure is elevated on the left heart. So normally, a right ventricular pressure waveform looks like this. So you have an end systolic pressure, you have an end diastolic pressure, you have a diastolic pressure gradient, you have your pulse pressure, a positive and a negative DPDT. When the RV function deteriorates, what will happen is the RV and systolic pressure will go down and the end diastolic pressure will go up. The pulse pressure will go down, and what you'll see is an increase in your end diastolic pressure gradient. And the waveform will look what is called the square root sign. The DPDT will be reduced and prolonged in diastole. PA pressure, we all know systolic, diastolic. And when you combine it with the right ventricular pressure waveform, you'll see there's going to be a gradient in diastole between the two pressures. This is the PA pulse pressure. And the PA pulse pressure is very useful because it's been used to calculate PAPI. And the PAPI is the pulse pressure divided by the CVP or the RVEDP. Okay, so when you use a conventional SWAN, people would look at the PAPI and say, this patient has right heart dysfunction. But if you use right ventricular pressure waveform, you don't need to calculate the PAPI because you see it right away, instantaneously. So the PAPI has been shown to predict right ventricular failure after LVAD in several studies. So when you have RV dysfunction and failure, what will happen? Again, your systolic PA pressure will go down, the pulse pressure will go down, the diastolic pressure will go up. And then what will happen is that the end diastolic pressure of the RV will go up, and sometimes it can even equal or even go higher than the PA diastolic pressure. So the PAPI will go down. Why? Because your pulse pressure is falling, and the RVEDP or the CVP will go up. Okay. So this is an example of a patient who's developing severe RV failure. First, this is what the waveform looks like. And you can notice that in yellow is the PA pressure, and in green is the RVEDP pressure. And at a specific point, the pressure in the RV is higher than the PA pressure. And this will lead, and the other elements also that you'll notice, whenever you have RV pressure, if you have a radial artery pressure, you have to be careful because often it's going to be completely unreliable because often these patients on a high vasoactive drugs, and then the pressure, the pressure on the radial will be unreliable, as you can see in this example. So what will happen on TEE is this. So if you look carefully, what you will see is that during diastole, you'll see the pulmonary valve will open, okay? You'll see, and then you see that during diastole, the pulmonary valve open. And then if you put pulse wave Doppler, what you'll notice is that you'll see a positive signal during diastole. Okay? And that's a sign of severe right heart failure. It means that the RV and diastolic pressure is higher than the PA diastolic pressure. And this is not something new. In 1985, mid-diastolic opening of the pulmonary valve after right ventricular infarction was described in JACC. And you can see it here. But this was described like, an observation. But when you use RV pressure waveform, you can see it instantaneously. And then you can look for the signs with TE, which confirms that this condition. 54-year-old man, coronary revascularization, aortic valve repair. We're weaning from bypass. Again, you know this gradient between the radial and the femoral. And yellow, pulmonary artery pressure, green, right ventricular pressure. You can see ST changes, and we'll see why do we have ST changes often when we have RV dysfunction. But when you look carefully a little bit later on, what you notice now is you still have the ST change, but now you have a diastolic equalization of your right ventricular pressure waveform. They are completely equal in diastole. And you notice also that the DPDT is not perpendicular, it's slow. So there's a reduction in the function and the performance of the right ventricle. So when we see this situation, the strategy that we use at the Heart Institute, basically two strategies. One is we often use intratracheal Merino, okay? And because the advantage of getting intratracheal instead of getting intravenous is that you don't have systemic hypotension and you don't have shunting, okay? So that's the advantage. The other strategy is to use noradrenaline. So this, when you look at the contemporary management of right heart failure, and what they will say is that the drug of choice is noradrenaline. Okay. And this is what we did. We gave a bolus of noradrenaline. And when you give the noradrenaline, what you see, the DPDT just becomes straight. And you can see that the slopes normalize. So you improve both the systolic and the diastolic function, most likely by improving your coronary perfusion pressure in this patient. Another example, this is a 56-year-old woman with who's going to go aortic valve replacement, ASD closure. When you look at the 2D image, you see the right atrium is distended. And one measurements that we can do with TEE is to measure the strain of the right atrium. So when you look at the strain of the right atrium, the value was 7.4%. The normal value should be 40%. When you look at the other components, the brain saturation is reduced. Remember, normal value should be around 60, 70. And when you look at the portal vein, it's highly pulsatile. So one of the other strategy that we've been using, and we're actually doing a randomized trial, is the combination of inhaled prostacyclin and inhaled Merino. And because they have two different mechanisms of action, the efficacy, the combination is much better than when you use them separately. So when you give the drug, you can see right away, just on the 2D image, that the right ventricular size has been reduced. You can see that the strain went from 7 to 21%, but you can also see the extra cardiac effect of this therapy. The brain saturation really went up, normalized, and there's no more portal possibility. There's no more venous congestion in this patient. If you look at the right ventricular pressure waveform, you can see there's an abnormal slope, and then it completely normalized during diastole. So when we look at right ventricular failure, this was a review article in the New England in 2023. They describe all the different techniques that you can use. And when we look at the right heart catheterization, they do mention right ventricular and diastolic pressure. But the conclusion of the study is that what we really need is not just an information on the right ventricle, but we need to have an information of what's going beyond the right ventricle, what's happening in terms of right ventricular afterload. And this is what they call the ventricular pulmonary arterial coupling. And in fact, this concept is clearly associated with morbidity and mortality after cardiac surgery. So when we start using the right ventricular pressure waveform, this is something we were presenting at meetings. And then in 2017, Edwards came to us and said they didn't know that we were using their PA catheter for that purpose. So they contacted us and said, okay, we'll see if it's working, if your idea is working. So then what they decide to do in collaboration with Etienne Couture, who's a cardiac anesthesiologist and an intensivist at Quebec Heart and Lung Institute, is to do an animal study. And basically, what we did is that we created the ischemic model that looks like what happened in the OR. So it's an embolization in the right coronary artery and with biventricular pressure volume loop to see what happened, and also using a fluid-filled catheter and conductance catheter. So we create a progressive RV ischemic model, and we were looking at what will happen when we see the appearance of right ventricular dysfunction and failure. So this is what you have here is biventricular pressure volume loop using conductance catheter. You have the right ventricle on the left side of the screen, the left ventricle, and the injection is the number of microsphere that were injected in the right coronary artery. So it really looks like what happened in the OR when you have air embolism. As the number of injection increase, you can notice that the right ventricle becomes bigger and the left ventricle becomes smaller. Okay? And you can also see carefully that the diastolic slope is gradually changing as we are developing right ventricular failure. So this illustrates the interaction between the right and the left ventricle spontaneously. So as the number of injection increase, you can see that you move from an oblique to a square root sign, but also you can see this, not only the slope that changed, but the right ventricular and diastolic pressure becomes higher and higher as you develop right ventricular failure. So this was an interesting article showing that basically the right ventricular pressure waveform is probably our best way to look at this interaction between the right heart and the pulmonary artery. So this is the mean pulmonary artery pressure, ventricular elastance and volume on the y-axis, and on the x-axis is the pulmonary hypertension staging. So, and on the right side is the ventricular, the coupling, the ventricular to pulmonary coupling and the stroke volume. So this is normal, coupling maintained, uncoupling. So what happened is that as you develop pulmonary hypertension, your heart will compensate. Okay, at one point you're going to increase your contractility, and that's called the André effect. And anytime that you notice when you have an apnea, when you're doing 3D, just do the strain before and at the end of the apnea, and you'll see the strain will increase. Okay, and that's really an AMREP effect because the higher CO2 will increase pulmonary artery pressure, and the contractility will increase. That's a normal response. But at one point, it will stop to increase. The ventricular elastance will increase, and when you're going to start to uncouple, then it's going to start to fall. And then the stroke volume will be maintained until you're uncoupling, and the right ventricular volume will start to increase when you're uncoupled. The coupling indices, the ventricular over arterial elastance, will start to fall when you're there. So the right ventricular pressure waveform tell you where you are in this relationship. So when it's completely flat in diastole, that's normal. When you're starting to have a coupling which is maintained, then you're going to start to have an oblique slope in diastole. And when you're going to be uncoupled, this is when you're going to have your square root sign on your RV pressure waveform. And when you have a gradient, that means that your contractility is significantly increased, and that means that your coupling is increased in those patients. So the first study we did using right ventricular pressure waveform was published in 2020. It was a retrospective study. We look at cardiac surgical patient, and what we found is that if you look at all this population, the percentage of patients who have abnormal RV diastolic pressure waveform is between 42 and 48% before bypass. It was associated with RV diastolic dysfunction, pulmonary hypertension, difficult separation from bypass. But what we found, the most important parameter, was the right ventricular end diastolic pressure, which was clearly associated with difficult separation from bypass in this retrospective study. Then we did a prospective study. Then we selected patients before cardiac surgery. This was not all the patients. And this is what we report in terms of gradient. What's the normal right ventricular diastolic pressure gradient? It should be normally around 4.5 in 105 patients before and after bypass. And when you look at the right ventricular end diastolic pressure, you can notice that the vast majority of our patients have higher RV-EDP compared to what should be the normal values around 8 millimeter of mercury. So in that study, we had 45% of our patients who had difficult separation from bypass, 17 with severe RV failure. But when we look at the diastolic pressure and the gradient before bypass, there was no difference between those who had difficult separation from bypass or right heart failure. But what we found in that study is that the major determinant of right heart failure is the number of emboli that you will have during cardiopulmonary bypass. And this is what it looks like. So what you have here is transcranial Doppler, and all the yellow, the lines that you see are high intensity transient signal, which are hits, which indicates most of the time air embolism into the brain. And the reason why we have right heart failure, well, the hits explain why the ST are changing, okay? Because they go into the right coronary artery, and you can see it sometime with TEE. You can see the air just going into the right coronary artery. And when the number is significant, then what you will see that they will accumulate in the RCA territory on the left side, causing LV dysfunction, okay? So that is for us was a kind of a clear demonstration that this is an important factor, and it stressed the importance of de-airing. The de-airing is so important by the cardiac surgeon. 54-year-old cabbage AVR coming off bypass. You can see there's some RV dysfunction. By no surprise, brain desaturation. That tells you that there's something going wrong as we're weaning from bypass. Why do we have this? Well, that's the total number of emboli that we have on the left and the right side. Significant amount of emboli, and by no surprise, big gradient, radial femoral, and you can see square root sign with the RV. So that makes the link between all these different elements that we've been observing in our patient. 2024, Stéphanie Jarry, former PhD students, we report our preliminary experience on 354 patients who were monitored with transcranial Doppler. And clearly, if those who had difficult separation from bypass had way more emboli than those with easy separation from bypass. And if you have a high embolic load, this was associated with persistent time of persistent organ dysfunction that was described here. This is one of the parameters that we use as an outcome measurement. Longer stay in the ICU, longer duration of vasoactive drugs, and higher mortality compared with those with no or very low embolic load. So let's talk about now the systolic component of the right ventricular pressure waveform. So when you have, during systole, what will happen with the right ventricle, you're going to have radial shortening, You're going to have longitudinal shortening that we measure with TAPSE, but you have also a sequential motion with the right ventricle. And this is a very interesting. If you look carefully, you'll see that the contraction of the outflow is much delayed compared to the inflow. And this is also very important in the differential diagnosis of right heart failure. When you have air emboli and RV dysfunction and air emboli, you will preserve the outflow tract contraction. And often, sometimes you even have outflow tract obstruction, okay? Because the emboli will go in the more medial and distal part. However, if you lose the contraction of the conus, that means the distal part of the outflow tract, that means there's a proximal obstruction, okay? And that tells you that the mechanism is completely different, unlikely to be secondary to air embolism. So that's a very important information when you're looking at the causes. So the majority of right heart failure that we see, often they have preserved outflow tract because the conal artery is not obstructed necessarily by the air. So this is a 69-year-old woman, mitral and aortic valve replacement. And what I want to illustrate you is that if you use a CVP waveform instead of right ventricular pressure waveform, the waveform of the CVP in diastole is identical to what will be on the right ventricular pressure waveform in diastole because the valve is open. So just with a CVP, you can diagnose RV diastolic dysfunction, but the scale has to be reduced. If you have a 50 millimeter scale on your screen, you won't see this. But if you reduce it, then you'll be able to see this. However, if you just use a CVP, you can diagnose RV diastolic dysfunction, but you miss everything that's happening during systole. Okay? So this is the CVP, the pulmonary artery pressure, and you notice that it's exactly the same. And this is the Y descent, and the Y descent is clearly a sign of RV dysfunction. Okay, so and this is the corresponding pressure waveform. And when you look at this paper in 2022, they would say, like, what do you have on your PA catheter that tells you that you have RV dysfunction? And they would say prolonged RV diastolic plateau, but also a Y descent deeper than the X descent. Okay, so that's something that you can see on your CVP, that there's some RV dysfunction also happening. So normally there's no significant difference in systole between the pulmonary artery and the right ventricle. Should be less than 6. And we talk about right ventricular outflow tract when it's more than 6, when it's more than 25. Now we're talking of severe right ventricular outflow tract obstruction. You can see it in some cases. You can see the outflow tract contracting on itself. You see it easily on TE in the RV inflow outflow view. And you can also see it instantaneously using right ventricular pressure waveform. So this is an example of a severe right ventricular outflow tract obstruction. And in fact, the reason we got interested in this was a very similar case. So in 2002, I was called in the OR by one of my colleagues. They were trying to wean after aortic valve replacement, and they were on lots of inotropes. And then they were unable to wean, and they had to understand that the PA pressure was 82, okay? So I arrive, and then I look at the waveform, and the diastolic value was very, very low. So I said, you're in the right ventricle. And then we just advanced the swan, and the PA pressure went down to 30. So I said, because we didn't know that RVOT obstruction exists. So I tell, you must have a pulmonary valve stenosis, because that's the only diagnosis I knew. So we tried to look at the pulmonary valve, we didn't see well. And then we even asked the surgeon to take an epiaortic probe and put it on the pulmonary valve sterilely, and there was no obstruction. And then we just pulled back and said, oh shit, there's an outflow tract obstruction. Okay. And this is how everything started. And we said, now, and then I had the idea, well, we have the PACE part, maybe it's more common than we think. And as we were doing studies to see the importance of the outflow tract, then we discovered that the diastolic portion was more associated with difficult separation from bypass than the outflow tract obstruction. But when you have something severe like this, it has a name. It's called suicide right ventricle. Okay, and the suicide right ventricle is typical after heart transplant. Because after heart transplant, you have an RV that's strong, that's been used to have high afterload, and then you put normal ones. Okay, and then what happened? basically they just collapse. The outflow tract just collapse. Okay, so this is an example where you can see this, and sometimes you just put M mode, you can see the obstruction. And one clue that can give you an idea, if you don't have this one, that you have such a problem is that if you measure the pressure gradient across the tricuspid valve, then you'll have a gradient. You see here, the gradient was 48 millimeter of mercury. The CVP was 20, so the pressure should have been 67, but the PA is 34. Okay, so when you see a big discordance between the gradient across the tricuspid valve and what you have in the PA, that tells you that's probably what's happening in this patient. First study that we've reported in 2006, 800 patients, gradient more than 6, 18%, and more than 25, 4%. The majority of those patients with significant gradient were hemodynamically unstable. And then recently, we report a much more detailed study in which we were able to record the values. And what we found, again, on 400 patients, is that before bypass, it goes from 30, 36. After bypass, 43 to 47% of the time that you'll see an abnormal gradient. And when you see the gradient, it tells you often the cardiac output is higher in those patients with a gradient because it indicates higher coupling. Okay. When you have it before bypass, typically it's associated with drugs that will increase your ventricular elastance, inotropes, or reduce your afterload, such as Flolan. Okay, so either drugs will be associated with this. After bypass, typically we see this with intratracheal milrinone, higher heart rate, reduced fluid balance, longer bypass duration. The good news is that when you have it, you don't necessarily have prolonged TPOD, time of persistent organ dysfunction. However, those who had it before bypass are at more frequent renal replacement therapy. Those after bypass, longer duration of vasoactive support. We also did a systematic review. There's been 291 patients reported. The majority of these conditions are mechanical, about 20% iatrogenic, and it's about between 1 and 9% that's been reported. A common one is when you do a mammary artery on the right side, often you'll have compression of the outflow tract, and that's a mechanical outflow tract. And then you can have dynamic outflow tract, where you can see the acceleration in color Doppler in the outflow tract of those patients. This is a case we had a couple of weeks ago. It's a woman who came for aortic stenosis, and she had also an aneurysm of the interventricular septum. And what was interesting is that when we insert the PA catheter, you could see there was a gradient across the outflow tract. So the RV was 43 and the PA was 25. And we were wondering why was this, but in fact, the reason was that this aneurysm was compressing into the right ventricular outflow tract. So we could see the acceleration into the outflow tract. And that was the reason we had a gradient in this patient, was a mechanical gradient. The other value of using right ventricular pressure waveform is that you can see much better the effect of your drugs on the right ventricle. So this is a 61-year-old woman, coronary revascularization, off-pump bypass, and this patient will be given inhaled prostacyclin at 9 a.m. So this is the RV and the PA pressure. And what you notice is that shortly after, you can clearly see the effect of the drug on your DPDT. And you can also see the appearance of a gradient, indicating that your cardiac output probably has improved. And then you can see it also later on the waveform. And the effect of this drug was that this patient had portal paucity, which completely normalizes after the treatment. So if you just look at the PA pressure, you wouldn't see these change over time. But when you look at the RV pressure waveform, you see that the drug is working, and you have a confirmation of the extracardiac effect of the intervention. This was an interesting case report in 2024, dynamic outflow tract obstruction, and often overlooked cause of hemodynamic instability after cardiac surgery. And the author mentioned that you should suspect RVOT when there's the discrepancy between your conventional Swan-Ganz and what you're seeing on echo. And this is just an example to show you this case. So this is a 64 man after intratracheal milrinone, and you can see there's a gradient. There's a 20 millimeter of gradient. In this patient whose blood pressure is maybe not optimal, you could calculate the PAPI, and the PAPI will tell you that it's abnormal. It's 1.3, okay? But you agree with me that when you look at the echo, there's no evidence of RV dysfunction or failure, okay? So that's one of the pitfall and limitation of the PAPI, is that if you have an outflow tract obstruction, it won't correlate really with what you're seeing. So that's why I would say, instead of guessing that you may have an RV dysfunction, why not using the RV pressure waveform, and you'll see it right away. So at the Heart Institute, the swan we've been using since 1993 was this one, where you have the pasteport swan and the PA pressure. And one of the problems with this one is that I would say 85% in big patient, you get a good signal on the RV and the PA. But what can happen also is when you have smaller patient, what will happen is that as you advance in the RV, you're going to wedge distally, okay? And this is not the ideal situation. So one of the proposition that we made to Edwards is say, why don't you make a swan with a more distal opening at 13 centimeter? And that's basically what they did. And we validated this, the swan gans, and this was a letter to the editor. And basically it works almost, in this case was 98% of the time, but the three reasons it didn't work, it's just because one of them didn't cross the tricuspid valve, or there was an SVC occlusion. But all of them, you can have the waveform within 50 centimeters. So far, we're actually doing a study. We had 12 patients recruited and 100% success. So you advance, you don't need to go far, and you have the RV and the PA waveform right away. So this is what the new swan gans looks like. It's called the IQ Swan, and it has a port, RV port, which open at 13 centimeter. It has also mixed venous oxygenation. And then you have this connector, which use artificial intelligence to calculate, to quantify all the parameters on the RV pressure waveform. So the first elements before this was available commercially, there was an animal study which was performed. And basically what was done is that use a flow probe, a ultrasonic probe around the pulmonary artery. And this is the gold standard to measure flow across the pulmonary artery. And from flow, you can derive volume. And then this was correlated with the right ventricular pressure waveform continuously under various conditions. So modification of preload, afterload, and contractility. And this is just an example of one animal. So what you have in what you have here in light blue is the flow probe, okay, it's the gold standard. And the black line is what they call autoencoder. So that's the value which is derived from the right ventricular pressure waveform that will provide you with the cardiac output of the animal. And the stars, the orange stars, are intermittent cardiac output that are measured during things. So you can see there's a very nice correlation between the two systems. And the use of waveform to calculate cardiac output is not something that we already use. You know, we use it for the flow tract using the arterial pressure. It's been shown with the pulmonary artery pressure. People have been using this, but this was a demonstration that we can also use the right ventricular pressure waveform. It's basically a flow tract of the right ventricle that we are using. When you look at the correlation between the transonic flow and the autoencoder, the precision is very good. And the precision is not as precise when you compare it with intermittent cardiac output. But in some centers in Germany now, they've been using for a year, and basically they stopped doing thermodilution. They just are using the catheter to estimate their cardiac output. So this is the validation, the human validation study. It was an international study which was performed in close to 400 patients. And just to give you an example, they wanted to have a very large distribution of cardiac output. And for instance, in the University of Melbourne, where they do a liver transplant, you can see this is a center where they have huge cardiac output. And they were able to correlate these significant change in cardiac output with the RV pressure waveform. This is an example of a patient undergoing cardiac surgery. And what you have in orange is the right ventricular cardiac output, which is corrected with thermodilution. So whenever you do thermodilution and you have the continuous cardiac output, you can tell, okay, you're measuring 5 liters per minute. I'm measuring 4 liters per minute. And you can tell, okay, now your 5 will become 4 and we'll adjust it. In blue, no correction. Okay? And the black box are intermittent cardiac output. And you can see that even without correction, the tracking is relatively good. And this is a case of liver transplantation, the same good correlation between the two. And the box correspond to thermodilution cardiac output. This is the blend almond for on top, the human study and the animal study. And the results were good enough, so that it was approved by Santé Canada, European Healthcare, and the FDA also. So this is an example of the display that you can use. And in fact, the display on the Alta monitor, you can decide whatever you want. You have the possibility of having 10 parameters that can be displayed. And this is the one that I've been using, based a bit on the experience of my colleague in Germany also. So what you have here on top is your right ventricular pressure waveform. Here is your stroke volume, but I use the stroke volume index based on the body surface area. And you have on the other side your cardiac output. Then you can have continuously your DPDT. And here you have your diastolic gradient, okay? Your end diastolic and your early diastolic gradient. On the other side, you'll have your mixed venous O2 that you can also calibrate with a blood gas. That's what we do in our research project. And here you have brain oximetry. And Edwards, now BD, has bought the Foresight company, and that's the one they've been using for that purpose. So this is an example. I just show you a couple of examples. So far, we've done only 22 cases, so we're still learning about it. We have lots of experience with RV waveform, but with this type of monitor, this is new. But just to show you an example, this is a patient before and after noradrenaline. So when you give your noradrenaline, you're not surprised to see your pressure goes up, your end-tidal CO2, which indicates that most likely your cardiac output has increased, but indeed, your cardiac output has increased. You can see it here. And you can also that the mixed venous also increased in this patient. This is another case where you give a small bolus of noradrenaline. And what's very interesting is that, again, your blood pressure goes up. Here, there was a much greater increase in the end-tidal CO2. You can also see the significant increase in your stroke volume index and your cardiac output. But again, what's very interesting also is that when you give noradrenaline, you're also recruiting venous blood. Okay, and that explains why your RV-EDP has also increased, and that probably increased the filling of your right ventricle. So it's very interesting because we've been using these drugs all the time, but to see in real time how they act on the heart, the filling, the contractility, and the brain is something which is new for me. This is just to show you an example of a patient with significant pulmonary hypertension before and after bypass. And what was very striking to me, we always think that pulmonary hypertension is very bad, and indeed it's bad. But if you have a patient who's able to generate 80 millimeter of mercury, this patient, look at his DPDT, it's 500. These patients have huge DPDT, so they have significant contractility. And this was after bypass. And after bypass, the valvular problem was resolved. But again, you see the PA pressure is lower. The stroke volume index is a little bit lower. The cardiac output is lowered, but your DPDT went down. But globally, when you look at your filling pressure are relatively similar. But overall, the oxygen transport is good, even better than it was before. Okay, so this is something I think will be very interesting to explore in further detail. What we have here is the transcranial Doppler. And transcranial Doppler, the new modality, the robotic, it gives you in real time what's happening. And what you see here are the peak of emboli at the end of bypass. So you can see exactly when the emboli are appearing during surgery. And this is just to show you an example of a patient which we give calcium. And when you give calcium, you can see that the right ventricle becomes very hyperdynamic, and you can see right away the DPDT, but look at the outflow tract. So when I mentioned, when you have an Earl gradient, an outflow tract gradient, it means that your contractility has improved, and then you can see it in real time. So in summary, this was an editorial that we wrote with Étienne Couture and Manon Canvin, and we said, why should we monitor? Personally, if I don't have a swan with RV pressure, I don't find the swan very useful, because the swan without RV pressure waveform cannot give me a diagnosis. And now the swan has the ability to give me a diagnosis. And if your PA pressure goes down, but you know that your slope is completely flat, you know the problem is not the RV. Okay? You know that the problem is filling pressure or vasodilatation. And the treatment might be to give fluid or to recruit from noradrenaline. However, if you have the same reduction in your PAP and you have a square root sign, well, if you look at in the paper in anesthesiology, the treatment is not volume. You're just going to deteriorate this patient. The treatment is to address right ventricular dysfunction. And that could be explained why we have such a high mortality with RV, because we don't have this feedback on what is it the good thing to do. And because at certain point, and we see this, when you push fluid, you're just deteriorating the RV. And in the OR, when it's very useful, that's we're coming off bypass, and sometimes you give back the blood. And I always say to the person, stop there, because we're deteriorating the RV. And you see it in your eyes that the cardiac output is not coming down. It's not coming up, it's coming down, and the brain saturation is falling as you're transfusing blood to this patient, which is not your objective. On the other hand, if your PA pressure is high and you have a normal slope, a normal brain saturation, that means that you're still coupling, you're still having adequate coupling. But if your brain saturation is down and you have a abnormal slope in diastole, you're really going to do bad. You're really in the uncoupling region. And finally, if you have an outflow tract, that means your coupling has improved in your patient. The majority of the time, I would say, as long as you're not more than 25, this is a good sign. This means that the patient is improving, is responding to the inotropic agent. So in conclusion, right ventricular dysfunction can be identified visually using echocardiography or using RV or CVP waveform analysis. If you use CVP, you have to zoom your CVP to see the waveform, and then you can make the diagnosis. Altered RV-PA coupling can be estimated using RV pressure waveform, which gives you instantaneous and continuous feedback on your RV systolic and diastolic function in response to treatment. The Alta monitor can now calculate continuous cardiac output using the RV pressure waveform, does not necessarily require calibration, and those parameters can be obtained continuously with the new SWAN. So I just, when I presented at the CS last year, I found this paper that Earl Wynands wrote, said, why publish? And what he said is still present. There's still many unanswered questions. And this is why it is so important that the generation that will follow us, the current generation, needs to continue to do research. If we don't do research, we'll just repeat what we have done before. We'll repeat the good stuff, but we'll repeat the same errors over and over. And it's only if we question what we do and we try to answer those questions, this is how we will improve our specialty. So what I presented you would not be possible without my students, my PG master students, and also my colleagues at the Montreal Heart Institute. And again, thank you very much for your invitation.
Thank you very much, André. Very data-driven approach to things. I don't see any questions online yet, so I'll ask the audience if there's any questions. Robert.
Dr. Denault, thank you. That was brilliant. You mentioned the flow track compared to the new RV PA waveform technology. The flow track is weak when there is vasoconstriction. So the vasoconstriction we have, or endogenous vasoconstriction. Why do you think the RV pressure waveform doesn't have the same weakness when obviously there's changes in PVR?
Yeah, so this is something we'll need to study. We'll need to look into because it's just brand new. The key important element with the RV pressure waveform is to make sure that you get a good waveform, okay? And if ever the waveform is abnormal, bad quality, you'll have a bad output, you'll have a bad cardiac output, that's clear. The other thing also is that the RV EDP has a fast response system. So if ever you have the RV EDP and you just do a flush test, within 6 seconds, the number will disappear. Okay, so it really depends on adequate RV pressure. However, in the current version of the Alta monitor, the cardiac output and the stroke volume might stay there up to 1 minute. So you have to be careful about this. And that's something we told the company that they need to move away. But so far, if you have a good right ventricular pressure waveform, because if your pulmonary vascular resistance increase, your PA pressure will go up and your RV pressure will go up also. So you will be able to track the change in your cardiac output as long as the right ventricular pressure waveform is of adequate quality. The flow track, they've been using we don't use them necessarily in the operating room routinely, but the flow track has the limitation that you mentioned. And often they will always want, ideally, to use your flow track on a femoral or a more central artery pressure rather than a radial artery pressure because of the problem of the gradient that we've encountered with this type of monitor.
I'll ask a question, Andre. You described a lot of intraoperative monitoring. This carries on out in the ICU, I take it?
Yeah. So far, we continue the monitoring of brain oximetry and process EG. And if we have a PA catheter, they will continue the monitoring. So far, we're just introducing the Alta monitor in the operating room. So at this point, we're still not using it. We're not really already using it in the intensive care unit. Eventually, they will replace the other monitor. The Alta monitor is basically a platform that will replace the hemisphere. So that's something which is coming up. But so far, it's not there right away in the ICU. Regarding other types of monitor, transcranial Doppler is not necessarily used in the ICU because when you use transcranial Doppler, you need to have a very stable patient, and we just have one monitor also. So we keep it for research purposes in the operating room.
Okay, thank you. In the absence of questions, I think we probably all need to get somewhere now, and we'll take the time when we meet you individually to ask more of you.
Great.
Thank you very much.